Good morning, everyone. Good morning. Am I on? Yeah. Okay. Great. Welcome to the American Enterprise Institute for today's discussion about the future of healthcare reform. I'm Joe Antos. I'm the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at AEI, and I'm delighted to be inside today. Contrary to what some have claimed over the last year or two, there's no shortage of proposals to replace the Affordable Care Act from Republicans of all stripes, members of Congress, including Speaker Paul Ryan, who produced something called A Better Way, which you may be familiar with. Dr. Tom Price's Empowering Patients First Act, and other proposals going really over at least the last 6 years or so from members of the Senate and members of the House. Think tanks have also gotten into the act here, including AEI's project that we produced in collaboration with a total of 10 of our colleagues from AEI and other think tanks. So there's no lack of ideas. And the only question is, now that Republicans are in charge, is there a willingness to actually move forward? The proposals that we've seen in the past promote several common themes. Typically, they retain subsidies for people purchasing insurance on the individual market, but they change the way those subsidies are designed. They eliminate the mandate to purchase insurance, but they create new incentives for people to buy coverage. They create high-risk pools intended to stabilize the individual market. They transfer regulatory authority for the insurance market back to the states. Each of these proposals that we've seen in the past would, of course, repeal the Affordable Care Act, but put in its place a policy that promotes a more market-oriented, consumer-driven view of American health care. But the specifics matter, obviously. And agreement on the philosophy does not guarantee that there will be agreement among Republicans on the Hill or people in general about the individual provisions that would make up a replace bill. Our first panel will focus on what can or should be in the replace bill. Beyond the general principles, what is needed for a replace bill to ensure access to appropriate and ideally affordable coverage for everyone? I'm emphasizing access, not necessarily a guarantee that everybody must or will have coverage, but they have to have the opportunity to get coverage, and ideally, as I say, it should be affordable. What is needed on the way to this replace that would ensure that the individual insurance market will continue to operate while other changes are being implemented? And in particular, now that they are in charge, do Republicans support the ideas discussed over the past 6 years? And are they ready to put their re-elections on the line for them? The second panel will discuss the challenges of enacting such legislation in the face of a narrow Senate majority, complex legislative rules, and a tight timeline. But we'll start first with the first panel, and let me briefly introduce everyone here in the order that they will speak. First up is Scott Harrington, who is the Allen B. Miller Professor in Healthcare Management and Insurance Risk Management at the Wharton School at the University of Pennsylvania. Next up is Bob Reischauer, who is a Distinguished Institute Fellow and President Emeritus of the Urban Institute, and among many other things, former CBO Director. And then finally, Tom Miller, my colleague at AEI, will wrap up the panel, and then we'll have discussion, maybe arguments among ourselves and with the audience. So with that, Scott, please take it away.
All right, thank you. Good morning, everyone. I'm going to focus my remarks on the individual market and what a replacement bill would need to consider in order to make that market perform reasonably well. I'm not going to talk about timing of any repeal or replacement. I'm not going to talk about logistics. I don't have anything to say about Medicaid. I'm necessarily going to have to get into a few of the weeds. I mean, one of the things that goes on with the debate is it's at a very high and simplistic level, but now that we're at the point of actually talking about changing the law, it's necessarily going to have to get very specific. Now, let me just remind you what the Affordable Care Act did with regard to individual and small group health insurance markets. It provided guaranteed issue and guaranteed rating without regard to health status, a big deal. It did restrict rating based on age within a 3-to-1 age band, so older people can only pay 3 times as much as younger people. That was designed in part to make coverage more affordable for older people, but at a cost of having some younger people face higher premiums. The ACA provided minimum essential benefits, minimum coverage tiers or specified coverage tiers that had to exist in all the states. Its subsidy scheme is fairly complex. It's based on income, and there's also a scheme to subsidize cost sharing in addition to premiums. And of course, there's the individual mandate, which has what I think it's fair to characterize as modest penalties for noncompliance. And there are open enrollment periods every year and special enrollment periods where people can sign up for coverage. Now, the problems that have arisen, and these problems vary a lot across states. But generally, the markets do not appear to be achieving sustainability, at least at this time in many states. Take-up of coverage by the uninsured has been quite a bit lower than had been predicted. The risk pools are sicker and older than had been predicted. There's some at least anecdotal evidence that people have waited to buy coverage and then sign up during special enrollment periods when they need care. And then what gets the headlines, there have been fairly large premium increases, in fact, dramatically large premium increases in some states. And then sort of sitting back in the big picture, in a lot of states, premiums are high and cost sharing, deductibles, and co-insurance are also very high. So people of relatively modest means can look at this coverage and say, it doesn't seem to cover much, but then it's very expensive. The lowest income participants are heavily subsidized, both in terms of reduced deductibles, reduced cost sharing, and reduced premiums. But people that are much above 250, 300% of poverty, and especially 400% of poverty, have really gotten hit in some states in recent years. The other thing that's been going on is that insurance companies overall have lost a lot of money in the individual market. It varies across company, but overall the losses are big, and many companies have decided to pull out of the exchanges, at least in some states. Now let me touch on some key features of what a replacement might look like, and I would really commend the reports that Joe mentioned, especially the AEI compendium. It's really wonderfully done in terms of laying out the groundwork and some of the pros and cons of proposals. One thing that we would expect is a return of substantial regulatory authority to the states regarding minimum benefits and coverage design issues, as well as any pricing regulation. Second key component would be to change the form of the subsidy from an income premium-based subsidy under the Affordable Care Act to some form of refundable tax credit, most likely with the tax credits increasing with age to make insurance more affordable for older people. Now, a really key part of a proposal would be, what do you do about the problem of pre-existing conditions? The Better Way proposal basically would provide guarantees for people that are continuously insured. If a person had insurance, they would be able to switch insurers, move from the employer market to the individual market, and not pay premiums that reflect their health status. They would have guaranteed issue if they're continuously insured. There also would likely be an initial enrollment period where previously uninsured people could sign up and pay premiums that don't depend on their health status and would have guaranteed issue. Now, if people waited, if they didn't sign up or if they didn't continue coverage, they would lose the protections against being underwritten for pre-existing conditions. People that ultimately fell through the gaps ended up without coverage, maybe were very sick. The proposal would establish state high-risk pools with a certain amount of federal funding so that people could get some coverage, albeit at a higher price. Now, there's some issues here, very important issues. The details will really matter. One is the amount and the design of the tax credits. My opinion is they do need to increase with age. If older people don't get a bigger tax credit, I fear the coverage will be unaffordable and you'll get extreme adverse selection among older people. Another thorny issue, though, is should the tax credits be tied to income? It's not clear how a refundable tax credit system that isn't related to income can provide as much support to lower income people as under the Affordable Care Act. But if you start relating the tax credits to income so that lower income people get a bigger credit, it does complicate the system, and economists then worry about the impacts on labor supply and work effort. Another issue is whether or not tax credits should vary by region, because healthcare costs and health insurance costs vary a lot by region. If you have a uniform tax credit nationwide, that may not be ideal, but again, if you tailor those tax credits, you're opening up a can of worms in terms of complexity. Now, just a quick point. The Better Way proposal would not allow a person to give up their employer coverage and get a tax credit and buy in the individual market while remaining employed in the group. So the tax credit wouldn't be portable. If you're in a group plan, you're offered a group plan, you stay in the group plan. Representative Price's earlier proposal would allow that tax credit to be portable. In theory, having the tax credit be portable so that people could choose between coverage at work and choose between coverage in the individual market could be a good thing. In practice, I think it creates a lot of uncertainty, and I also have a great resistance of doing anything to undermine the employer-sponsored market, which insures 160 million people, and in my opinion is a bulwark against having future Congresses under future unknown scenarios really move towards expanding government insurance throughout broader segments of the population. Design of high-risk pools will be key. What you want to have in a high-risk pool is enough of a penalty so that people are encouraged to sign up and not go into the high-risk pool, but you also have to provide protection for people that do fall between the cracks. It's pretty clear to me that significant federal funding will be required to make this work. I would also like to see discussion of providing states flexibility, so maybe any federal funding for higher risk buyers of insurance that would go into a pool. Maybe there could be a single pool. Maybe that federal funding could be used to subsidize some people more directly without having the prices of other people have to go up to pay the costs. Now, this whole issue of what we call adverse selection and guaranteed issue. So we're in this world, we moved to this world where if you keep insurance, you don't have to worry about having to pay a higher premium or be denied coverage because of a pre-existing condition. You've got an initial sign-up period where you can take advantage of those protections. Will those markets perform well? Will there be a disproportionate number of people that are in poor health that will sign up in that initial enrollment period? Will people that lose coverage at work, say to be losing their employment, will they be disproportionately less healthy and as a result drive up premiums in the guaranteed issue market? This is an open question. A lot of people are going to say, and they're saying it already, that you have to have an individual mandate to make these types of markets work. But the individual mandate in the Affordable Care Act is really pretty weak. So if you design the incentives besides having an upfront mandate, if you have enough incentives for people to buy if they get hit later with some penalties, we may achieve some form of stability in this guaranteed issue market, but there might be conceivably be issues associated with that. The next thing related to that is I think we have to worry about instability as we make changes. Now, there could be significant instability during the repeal and replace debate, but I'm thinking ahead to, let's say we have a replacement plan. Will markets be stable? Will this guaranteed issue market be stable? My training in insurance economics and my conversations with actuaries lead me to believe that companies are very nervous about having a whole new set of rules, a whole new underwriting pool, and they worry about what the risk pool will look like. I think it would be desirable to give very careful consideration to some form of stability mechanism for some number of years to ensure or help ensure a stable market as we move to the new world. Now, this gets politically very touchy because stability mechanisms can be things like reinsurance and risk corridors, which Republicans to some extent have viewed as anathema. And clearly, I believe the risk corridor system under the Affordable Care Act, which ostensibly was going to protect companies against adverse claim costs from a worse than average risk pool. I think it encouraged overly aggressive pricing, and there were issues with it, but I'll just leave it simply to say I think some stability mechanism really would be desirable to make sure things work. Now, one other comment, and I don't know where to go with this except just to raise the issue. I'll call it the coverage design quandary. Academics and practitioners and most people think that basic coverage should include catastrophe protection, that no matter what coverage people are buying for health, it should cover the very high end. There should be no limits, no lifetime limits, no annual limits. The problem is that many buyers of modest means are likely to prefer coverage if they have to have a trade-off between getting coverage for the very high cost stuff, which likely won't happen, and things that are more likely that may involve modest expenditures, $5,000, $10,000, $15,000 a year. A lot of people of modest means are going to really want to get something covered at that lower end. And I'm not talking about a $100 deductible, but I'm talking about that $5,000, $7,000, $10,000 expense that can be very damaging to people of modest means. And I worry that our emphasis on catastrophe coverage can give rise to a situation where people of modest means, they'll either see a policy with a very high deductible, which protects them against very rare events, but they don't view it as very attractive because it doesn't help them pay the bills and meet their obligations every month. On the other hand, they might get richer coverage, which does provide more coverage for more modest expenses, but the premiums will be so high that they basically view it as unattractive. Both of those phenomena can reduce take-up, and it can make voters unhappy. I don't have an answer to this question, but I do think sometimes we underestimate the desire and the need for people of relatively modest means to actually have insurance that pays for that shock to expenses that they really can't budget for. Health savings accounts, if they're promoted, clearly can help, but I think maybe we could think more about, is there a way of providing some form of subsidy to maybe subsidize that catastrophe coverage so that people of modest means would be able to use more of their dollars on things that might really matter to them more of the time.
Great. Thank you very much, Scott. Bob?
Thank you. It's a pleasure to be here in AEI's new home, and I'm glad they've preserved the historic aspects of the building. I'm just going to make 6 rather simple points. And the first of those is that if the last 6 years has taught us anything, it's that if we want major health reform to be politically sustainable, it's going to have a modicum of bipartisan support. And that's both a political reality and a procedural imperative. It's a political reality because the health sector constitutes 1/6 of our economy, involves a service the vast majority of the population thinks is absolutely essential, and is represented by powerful interest groups, employs millions of workers, and not all of the folks involved in this are Republicans or are Democrats. It's a procedural imperative because while partial repeal of the ACA, which is what the Republicans are proposing, can get through the Senate with a simple majority vote using the budget reconciliation process, that's not the case for a comprehensive bill that would replace the Affordable Care Act, because the reconciliation process is limited to legislation that affects only taxes and mandatory spending. So a replacement is going to have 60 votes in the Senate, and that's almost assuredly going to involve attracting somewhere between 8 and more Democratic votes. Second point I'd make is that taking together the goals that have been articulated by the incoming administration and by many of the repeal advocates are impossible to achieve. To refresh your memories, these promises include, first, sustaining or broadening the number of folks with insurance. Second, making health care more affordable for Americans. Third, improving the quality of care. Fourth, reducing government health spending. And fifth, providing more flexibility and choice and fewer regulations for states, providers, and participants. There's going to have to be some trade-offs made here. All of these can't be achieved if the bar we're comparing this to is what exists today under the Affordable Care Act as opposed to what existed pre-2010. Third, crafting, enacting, and implementing a replacement for the Affordable Care Act is going to take a good deal of time. 3 years, I think, would be warp speed for our legislative process. Notwithstanding what Joe said, at present there really is no consensus approach, let alone any specific agreed upon plan among Republicans. As he said, there were ideas, there are philosophies, it's a very rich menu, but that's easy to do. Writing the legislative language is much, much harder, and there are going to be complexities, there are going to be controversies, as Professor Harrington pointed out. Once a Republican consensus emerges, it's going to have to be modified to attract some Democratic support. Then the CBO is going to have to score this legislation, and none of these philosophies, ideas, whatever, have been scored the way CBO scores them, and the results are going to be compared to what a continuation of the Affordable Care Act would involve. That could send the policymakers back to the drawing boards for, shall we say, a few adjustments. Our legislative process is not known for its speed. Several committees in each chamber are going to have to do their drafting. There are going to have to be floor votes in the House and the Senate. There's going to have to be a conference to resolve the differences between the House and the Senate. Once the President has signed the bill, executive agencies are going to need time to write the necessary rules and regulations. I mean, notwithstanding the fact that we don't like regulations now, or we won't starting on January 20th, you can't just throw a bill out there with no rules and regulations on how the actual legislative language is to be interpreted and followed. Then you're going to need time for the various stakeholders, the insurers, providers, to prepare for whatever this new system is. I would be very surprised if individuals who are not covered by employer-provided health insurance are able to enroll in whatever the new system is much before January of 2020. So we're talking, I think, about taking a deep breath and going about this in a very deliberate kind of way. And it's worth remembering that this isn't the only thing on the plate of policymakers. We have tax reform, we have infrastructure, we have reforming entitlement programs, increasing of military spending, reduction of domestic discretionary spending, all very complex and controversial issues which are going to be going on at the same time. Fourth point is that the affordable care marketplaces are in shaky shape and are going to need some shoring up. And this was true, whether Clinton won the election or Trump won the election. We were in a situation where some reinforcement is needed, whether it's to keep the exchanges going permanently or just in an interim period before a new system can be put in place. We need to ensure that enough insurers are offering a sufficient variety of plans in the various exchanges. We need to provide insurers with workable mechanisms for managing unpredictable risk and to compensate them for adverse selection, which hasn't really worked out as was intended under the Affordable Care Act. And we also need to reduce the uncertainty among providers and insurance about what might come next. Repeal without concurrent enactment of replacement will create greater uncertainty, and without some remedial assistance and intervention, I think the exchange component of the Affordable Care Act will begin to crumble very shortly. If a decision is made to repeal the individual mandate immediately, and that was what a component of the reconciliation bill that was vetoed by President Obama in January of 2016, or a decision was made to drop the cost-sharing suit that is currently on hold, this process of unraveling could occur much, much faster. Fifth point, while a substantial fraction of the voting public may not like the Affordable Care Act as a whole, they like many of the parts, and they know about, and they like the consequences of some of the provisions they aren't very familiar with. Some of the parts they don't like were thought to be necessary to ensure that the parts they do like function effectively, and Professor explained one of these, which is the unpopular individual mandate and the tax penalties for failure to maintain adequate coverage were the pill that we had to swallow if pre-existing conditions were to be covered and medical underwriting was going to be limited. Now, as he has explained, advocates of replacement plans have proposed alternative mechanisms that might encourage high participation rates on a voluntary basis, like premium surcharges on those who don't maintain continuous insurance coverage. But we don't know whether these approaches will work. They could prove to be horrendously complex to administer and prove to be quite intrusive. Remember, you have to keep a record of every month that every person has insurance, and the insurance maybe is given to a family, but the family begins to split, and then as the kids get older, and then you have to keep track of everybody. And so, you don't like complexity, you don't like intrusiveness before. Well, here it is in a different flavor. Sixth point, and final point, while many of the public may not like certain aspects of the Affordable Care Act, that doesn't necessarily mean that they're going to be enthusiastic about some of the alternative approaches that have been put forward, nor does it mean that these approaches would be devoid, as I mentioned before, of complexity or implementation difficulties, just as all the complexities of the Affordable Care Act ran into trouble. And let me just illustrate this by saying a few words about two components that have been put forward by advocates of replacement. First, opponents of the Affordable Care Act like to rail against the Cadillac tax and suggest that in its stead an upper limit be imposed on the tax deductibility of employer-paid premiums. But would a deductibility cap, which would be passed through to workers, be as effective at incenting employers, who after all make the decisions on what kind of insurance the workers are given a choice of, would that be as effective at restraining costs? When it's on the employer initially, not that the employer wouldn't pass it down in an invisible way, the employer is making the decision with the insurance company. When it's passed to the various employees, it becomes a different mechanism for exerting pressure. And would the design details of a cap on tax deductibility prove any more popular than the unpopular detail of the Cadillac tax? You still have to decide whether to vary it by the health status of the firm's workers, geography, the costs of healthcare in different areas, the riskiness of the occupations that the workers are doing. Then there are the myriad of implementation decisions, like how would employers allocate the proportion of the premium above the deductibility cap across their workforce. We now have different categories. Different firms have different categories. Individual, family, adult with child. They aren't generally varied by age. How are the younger workers of the firm going to feel if really their coverage is well below the cap, but the average for the firm as a whole is above the cap? Would they want to be hit by that? A second example is a suggestion that a refundable tax credit equal to the value of the tax benefit associated with the average employer plan replace the premium subsidies that are provided to low-income individuals purchasing through the Affordable Care Act exchanges. Even if this credit were to vary by income as well as age, most would find the subsidy pretty skimpy. It's probably about enough to buy a bare-bones catastrophic policy and not much more. How's the public going to respond to that? and the complexities of the credit, which include such things as determining how to calculate the average tax benefit of the average employer plan, and how one would handle the differences between the tax filing unit and the insurance filing unit, would easily be as great and complicated as they are under the Affordable Care Act. So we're comparing sort of an image of the desirable to the reality of the Affordable Care Act when we talk about this. Let me just conclude by noting that contrary to what one hears in the political echo chamber in which we live, the public is not clamoring to have the Affordable Care Act ripped up by the roots and replaced with something new and radically different. The latest Kaiser Family Foundation poll found 26% of the country wants to repeal the entire law. 17% would like to scale it back. But on the other hand, 30% want to expand the law and 19% want to keep it where it is. In other words, we're split pretty evenly. We are a divided nation, which says that as we move forward, we should try to come together. And coming together might mean revising, reforming the reform, as opposed to trying to create something absolutely new and different because it has the label on it, Obamacare.
Thanks for that very optimistic view, Bob. But labels, labels do matter. Tom, you're up next.
All right, thank you. Good to be with you this morning. Joe, Scott, and Bob have done an excellent job of depressing us and dealing with the substantive elements of this. So let's move on to the entertainment portion of this reality show. A strange new group of political aliens landed in the White House and other policy centers of health policy last month. The previous incumbents and their allies and supporters are having a lot of trouble understanding them. They didn't seem to speak the same language, and that's not surprising. They didn't come from the same political universe. And the main leader seems to have 7 limbs, at least when seated in first class on an airline, at least so we've been told recently. So the translators here, a different kind of landing party, are still working on converting abstract symbols into something we can understand about what's ahead. Hold on a second here. Let's start by contrasting the different approaches by ACA supporters and opponents in constructing a reformed healthcare system. President Obama and his allies tried to build a very complex, huge, and expensive vehicle never seen before. Sort of like the fabled Spruce Goose of the 1940s, the Howard Hughes project, that ran a little behind schedule and budget and only got off the ground once. You might say it was too big and unwieldy to land on the runways of the time. Now, Republicans and their ACA opponents plan to build a much smaller health policy airship, very basic, stripped down, so almost anyone could fly it, truly consumer-driven, as it were. They just assumed that there'd be a runway where it can land safely. Just about any runway might do, but they haven't built one yet. Now, that fellow hanging out of the biplane was a member of the House Freedom Caucus who wasn't fully on board with the flight plan. All right, let's get to the basics. What's the game plan for Republicans in the ACA this year? Their main goals. Repeal as much as possible, and damn it, we're going to have to replace and revise as much as is necessary in that order. Some targets out there. Most of them have been discussed by Scott and Bob along the way. Who gets the money and where it goes. Regulation and mandates, individual mandate to take out early, hard not to do it politically, but a lot of the other regulations, because of the nature of budget reconciliation, hard to take out in the first go-round. Taxes, everybody wants to get rid of taxes. The problem is you have to replace the revenue and the kickbacks to industry. If you take them off, you change the leverage factors. Scott didn't talk as much about Medicaid. Medicaid passed over to the states. It's both a budget donor, which is a big deal, the only place where you basically get some of that balancing revenue, and it's also a place to say that problems are going to be fixed by someone else, and also the blame will be assigned to those who are fixing it rather than those in Washington. Big deal in terms of the federal role in healthcare and reducing it. And maybe along the way, this is politics settling some old scores. What might be some better steps toward meaningful reform? You know, this is the area where we all tune out, so you can just kind of read them yourselves, because the real details are not what most Washington observers are interested in at the moment, particularly. So I'll get to the main political horse race action at the pari-mutuel betting window. Even though I recommend all of these, it's like fly over land, because we'll do what we have to do regardless. The real political bottom line here from Republicans, after you blow all the smoke away, here it is. We won't reduce your subsidies very much. You got to make the numbers balance, but you know, basically no one's opposed to getting money in their pockets from someone else or thinking it works that way. But the most important point is we just won't interfere with it as much in terms of how you spend it. Of course, the one caveat, your mileage may vary in terms of how far you go with it. Now, there's some, you can't go that fast. That's the usual caution on this type of thing. A quick summary of the institutional factors, and Bob hit a lot of these. They're all important ones, but I underscore a couple of them. The path dependence, which is members of Congress and their staff have a great deal of difficulty in going in new directions. So where they were in the recent past, what they marked up is where they're going to go in the future. You can't rewrite the legislative text and pretend you have unanimity on these type of things, so you end up going in similar directions you did before. The transitions usually kill you, but also think about the different cultures and temperament of the House and the Senate. In the House, they're talking about regular order on replace. In the Senate, they're going, tie it all up in a bow after we've thought about it forever and then finally have no way to delay any further. They're going to operate very differently, and that's going to become a bit of a mismatch on the timing. Now, the danger is in all this, if you kind of move too quick, you might end up getting exposed while thinking you're playing out on the grand stage, and it turns out you're not ready to necessarily appear for the folks. But it is some risky business. Look, these are the different tactical moves. They're very good at this one, fire, aim, ready. They right out of the bat on that one. We've had the various alternative scenarios in terms of playing chicken and the mistiming. But the hard one is when you're trying to defuse what's already been out there, you know, cutting the wires on the bombs sequentially. And the example here is, you know, is it the green one or the black one? And what we have are kind of two mutual hostages theories going on, two different sets of bombs. The one on the right, I suppose, its dreams would say, well, we'll just blow up the ACA, full repeal, you know, no collateral damage, no harm. Well, there will be some harm if you don't blow it up entirely. That'll be a different type of political explosion that could go off. But the other one is from basically the defenders of the status quo saying, don't touch a thing. This was very carefully constructed. And if you just, you know, cut the wrong wire at the wrong time in the wrong sequence, not only will it blow sky high, we're going to have tens of millions of people without insurance coverage, tens of thousands of people, or the expectation of this, will die within the next year as a result of this. So that's the alternative hostage theory if you don't cut the wires carefully, and therefore you have very little maneuvering room and you end up back in the same place in terms of the status quo. There's some timing factors for major changes, and this is what's driving the process. You know, one point of view is, if not now, whenever, so you got to seize the moment, although sometimes when the bombs fly, it's not shock and awe. It turns out later on you've got the occupying force, it's shock and awful, if you recall our history elsewhere. But there is this pent-up political demand saying, you've been talking about this stuff forever, put up or shut up. And you're not going to get this chance again. As President Obama found out, he had a supermajority for 2 years. Things change. So if you don't strike while you've got it on the table, it could be a different environment. Other things begin to interfere with that. The lesson is we need to have more bipartisan gestures. But the other lesson is bipartisan gestures only go so far, and you start getting bogged down, and then you end up having to cut to the chase. And that's one theory of what happened about 7, 8 years ago. We'll see what happens this time around. But there is, you know, on the other side of this, reconciling the rhetoric to the governing realities and having to run again on those results, and that has a little bit of a disciplining force when you're firing real bullets rather than those in opposition. Nevertheless, I do think that there are going to be some real changes ahead in direction and emphasis, just never as much as either people fear or hope. So what are we going to have in that direction? More private, less public, matters of degree, lighten the load in terms of regulation and mandates, a rearrangement, but not necessarily a reduction of the overall subsidies in the system, and what goes with that is readjusting the winners and the losers. You reallocate the levels of decision-making, a little bit more back to the states, a little bit more in the hands of consumers, nothing crazy, and then what do we also get? new sets of overpromises, and developing new excuses and evasions. And if trouble really starts, what you resort to are the 3 Ds. Even though you don't do it necessarily on budget, more dollars are spent at the end of the day. They just have to get moved in other more creative ways. And then the other D is delay, which means, well, it's going to get there eventually, but it doesn't get there as fast as you can and kind of have to adjust on the fly. And the key one is definitions. You are going to get things said to be different than they were before. What you do to solve a problem is you invent a new acronym and you come up with another name for it. That usually works for a good day in Washington. So there are some imperatives that have to be done, though. You have to pass something because the alternative to that is just not very good. What you do is whatever you pass, you call repeal. It's just a matter of language, even though it doesn't come out the same way. And you have to develop, let me go back there for a second, develop some creative workarounds, all the type of institutional factors. They will be busted by a majority which has no other alternative to do it. We've invented them before, we'll invent them again in the future. You're going to have to recalibrate the incentive structure to deal with the current interests in place. The idea that it's going to be a one-sided, what do you need in the various industries is not how it's going to work. It's going to be actually changed around. The same way they were browbeaten in the last administration, that will happen when push comes to shove in terms of what keeps them on board because the alternative isn't really that attractive. Now, the problem is kind of this separation in time between some version of repeal, some version of replace. The goal is to compress that gap between the two, although the real goal is to make it never happen, but you can't do that politically. So in order to bring them closer together, you're going to have to, when you make your compromise and equivocations, emphasize that it's all being done for this clear commitment to higher goals we're all in favor of. Keep looking at that and don't look at the ugly details inside as we meander on down the way to trying to do that. There are some, I always come off as being so critical of the Affordable Care Act and Obamacare. I always like to give them credit as they're about to leave. It's kind of a valedictory. So let's talk about what was actually accomplished and achieved. Some failures, but also some great successes in the Affordable Care Act. They were able to change legislation without actually legislating. Good accomplishment. Fueled endless rounds of consulting and conferences, such as this one. We appreciate that. Didn't actually reduce costs, but again, shoveled them much more creatively than we've done in the past, and that's something to build on for the future. Set a new record for the longest opposition to a major entitlement program. 7 years after it's passed, we're still fighting about it. That's pretty good. Unable to shift all or most of the blame. Now that's a failure. It was an objective, but you couldn't quite get it all the way there. Substantially increased enrollment in high deductible health plans, more than any HSA legislation ever did. We just put them into the exchanges. And didn't actually capture all the states and reconstruct them, unlike General Sherman, because it didn't have the same amount of firepower and urgency. But, goals always come there along the way. Nevertheless, there is no substitute for claiming victory as a majority which wants to remain a majority. So as they used to say in Texas, there's no back door to the Alamo, so there's no surrender. The problem is that you need a lot more firepower to fight through the front door. Now, some of my friends in the conservative community say, we're going to repeal it anyway. In the background playing is the theme song from MASH, Suicide is Painless. I would just point out, though, that it may turn out to be a mutual murder-suicide pact. Thank you.
That was disturbingly upbeat.
Why do you have you on the panel?
Okay. Well, let's see. So we have a few minutes for. I had actually anticipated a little argumentation across the panel, but I see a certain common theme here. Let's start off with any of the panelists wanting to make additional comments at this point. Uh-oh. No commitments. Well,
going to revise and extend our remarks.
Exactly. I will make one comment, which is that I'll call it Obamacare for this comment. Obamacare had a huge advantage. It got there first, and so to some extent, by getting there first, it cut off many of the options that you might have rather done. In particular, although I agree with Bob's point about the difficulties of moving to a cap on the employer exclusion, nonetheless, had the Cadillac tax not come, maybe the cap, maybe every economist's dream of a cap on the employer exclusion for employer-sponsored health insurance might have actually been tried. It's hard to predict, but that's at least a pretty clear example that you can't go back. And you can't go back because it's one thing to take away a tax, but for Republicans and Democrats, it's another thing to put a new tax on. So that's a real problem. So the other aspect of this that has always struck me is that the Democrats really took the easy job, because it's very easy to find ways to funnel money into an insurance market and expand coverage. That's the easy part. The hard part is that affordable part, which Republicans have in essence said we're going to do.
You stole the name.
Well, that's true. So we'll have to have a new term for that. How about less expensive? Anyway, so it's not just an uphill fight for all the reasons that people talk about, but because there's already history. And it's not just the regulatory history, it's the political history that I think may be the biggest challenge of all. Anyway, with that bit of commentary, let's go to the audience. I'm sure somebody here must have a good, positive remark to make. And here's somebody up front. Please wait for the microphone. And it's going to take a little bit. And when you do get the microphone, please say who you are, and please make your statement in the form of a question.
Good morning, Lou Gagliano. I'm an independent healthcare consultant, and I work on both policy and new product technology that answers the question that I think is important, which is how do you improve the outcomes so you drive down the cost of care? And frankly, it's the best time I've seen in a long time, which is the good news, that a number of the programs that charge penalties and incentives are changing the direction of healthcare at the local level. And they hold great promise. And the ACO, the Community Accountable Care Organizations, ultimately will be a great model to drive down costs. And so I hope we don't lose in the shuffle of the national policy, which is kind of a very macro thing and will take more time, that many of these programs that are ongoing now, such as under the macro program, are incentivized. And frankly, we use the accountable care model to drive compliance on some of our Medicaid patients who are at the highest risk of incidence of episodes which aren't good. So the question is, how don't we lose in this kind of national policy, let's repeal Obamacare, which is going to take more time than anybody thinks, this emphasis on the good stuff that's happening?
Well, the first answer is they're not in great danger because most of the Republican policymakers never read that part of the law. So it's somewhat flyover land, and it's not a part of political contention. However, I would temper your optimism. I think what we've done a remarkable job of doing is expanding the vocabulary of delivery system reform and coming up with all kinds of theories and terms and not yet proven in order to feel good about that. Well, but when you pour through the actual evidence on the ground, there's a lot less there. And part of the problem is you can have all kinds of experiments which work very well for some experimenters. It's the scaling up, recognizing. So what I would hope policymakers would do would be stand back, wait till someone else succeeds at it, and then claim it was their idea and push a spotlight on it. That tends to be innovation through policymaking.
That makes sense to me. The other thing is, let's keep in mind that terms have to change. So we're not going to call them accountable care organizations because that's used up, right? But another factor is that people often forget. What's called the Innovation Center isn't very innovative because most of those ideas have been kicking around for decades. And furthermore, they haven't worked out very well. Not just accountable care organizations, but a lot of other things, partly because those ideas fall into the same category as philosophy that I was talking about earlier. Philosophically, they make sense. On the ground, how do you do it? And certainly having a system where you simply say, okay, this 2/3 of the country, you're going to do it this way, probably isn't a reliable test of whether something works or not. So there's a real challenge there. I'm a big believer in testing ideas, but I believe in testing, not simply, as Tom said, legislating without the use of Congress. Other questions? Let's see. Oh, actually, I think I saw you second, and then after that, I lost all track of who raised their hands.
Armin Choksi. All Republican plans talk about competition across state lines. How difficult is that to implement, and what would be the political forces that would impede that from going forward?
Well, I'm partly responsible for that, since I wrote about it about 14 years or so ago, hypothetically in theory. Couple of problems. Wrong moment, wrong time. Good idea conceptually, which is in its better iteration, you're really trying to create a consumer-driven competition in how health insurance is regulated. We've done this in other policy areas, and you get some variation. Federal regulation is one type of monopoly regulation which doesn't work very well. Just because you have a smaller boundary line for a state doesn't mean that the state insurance regulation is the only way to do it. If people don't like the regulation which is part of the product, they should be able to find something else as a component. There are some speed limits on this. The standard one thrown up is, well, you're not going to get a new entrant into a new market because you can't, get the provider networks, et cetera, et cetera, et cetera. That's trial and error. Someone has to find a different way to do things, put capital down, and make it a successful business. Sometimes you open a door and people come in, sometimes they don't. There are barriers we put in that way. The other is we're in the wrong moment in time. People point to like about a half dozen states did limited versions of trying to make this possible. Well, who's going to do anything when you just pass the ACA, which is compressing and making more uniform the regulatory parameters, so you don't have that variation by looking for regulation in other states. Now, it's the old, how do you become a millionaire, Steve? First earn $1 million. So the same type of thing is, Steve Martin, I always give credit for the jokes. If you first repeal the ACA or the federal regulation attached to it, and then you have a phase-in time where states begin to vary again, where there's a reason to want to shop somewhere else, then you might have a market opportunity, which won't save huge amounts of money, but we've looked at some numbers, and depending on the variation in mandates and other types of rating rules and other regulations, with some safeguards, which take that back, you might be able to save 10 to 15% on the premiums. If you also get the other miracle, which is a state insurance regulator saying, I'm not perfect, and they might have better regulations somewhere else, which is why you probably do a bypass with federal legislation to create a template where it opens the door regardless of a regulator saying you can't come into my state. So over the horizon, maybe. Right now, it doesn't really matter, but it's something that people talk about because they heard about it in the past, and it seemed like a good idea at the time.
I would add that anyone who implies that moving in that direction is some sort of a game changer really doesn't understand how insurance markets currently work and the intricacies associated with having that work out in practice.
It's also an issue that becomes rather complex because you have to decide, are there going to be national minimal standards for what we consider insurance to be? And if you're going to leave that up to different states, some state is going to permit rather skimpy packages or insurance that doesn't cover certain expense of mental health or whatever, and then go off and sell that, and it's going to undermine the risk pool in the other states, and everything begins to fall apart. So you get into a very complex.
The race works in two directions, though, Bob. It can be to the top as well as to the bottom. What you have to think about is, why do you have a mismatch between how you're regulating insurance in a state and what most of the people want to buy? That's only a problem if it's a problem, and that should tell you something about the regulation. So if you put in some other provisions which say you can't sell insurance in another state unless you sell the same dog food to the dogs in your state, you begin to kind of create those mutual incentives to say you can't get away with kind of just fly-by-night stuff, otherwise it'll come back to hound you.
Well, it wouldn't be extreme, but you would get a movement in that direction.
Which would be good. You're squeezing the outliers. Those who do too little regulation, those who do too much regulation have to move back toward the middle.
So on the one hand, the proposal is to devolve a lot of authority over regulation back to the states under repeal and replacement proposals. But on the other hand, we don't trust the states to develop regulations to protect their own citizens. And as good Republicans, we really want the federal government to tell those states what they can do. And I'm being, of course, a little satirical here. I have a problem with insurance over state lines and federalism. I think you have to pay attention. If New Jersey wants to have mandates, I want to know, how does it affect me in Pennsylvania? Now, if there's a spillover, then maybe we should go in and tell New Jersey they can't do something or undermine New Jersey's system. But otherwise, I think there has to be a certain amount of deference to state authority, and clearly the repeal and replacement proposals emphasize that the states can get this right, that they can come up with their own systems to provide affordable coverage without as many federal constraints. So there's a little bit of inconsistency in the dialogue.
Certainly, it's really annoying that health service markets don't align perfectly with state lines. But, I think we can fix that. Okay. Well, let's see now. Someone back there. Yeah.
Hi, Paul Heldman with Heldman Simpson Partners. So I heard this addressed in dribs and drabs, but I'm looking for a cohesive answer. What needs to be done to keep the individual insurance marketplace from eroding or imploding during the transition? And I ask that in the context of, when you think about it, you have a president, right, who expended a lot of energy trying to implement this law and get it signed up. It has his name on it. You're moving from that president to a president who doesn't believe in this law, and a regime that's saying, get rid of this law. And I wonder, that's going to have an impact in the marketplace in and of itself. So how do you address that?
All right, Scott.
Go ahead. I could clean up.
All right.
And think of something.
And this
You might try. This is a new concept: selling cheaper, more attractive policies to people who are willing to buy them. That's a starting point, and sometimes taking the regulatory lid off of that could help in that regard. Now, you can stage manage transitions however you want to. You flush dollars out the door to keep people at the table, or you threaten them with higher taxes for exiting those markets as the flip side of it when they don't do it. And they'll use both tools depending on whatever is necessary. But, and you can call risk corridors and reinsurance something else under a different name in order to basically pay off people to stay there for the short term. But on the long run, you're probably going to spread the subsidies for individual market to other groups of buyers who got left behind at the table in the outside market, and they're going to be happy about it. And you're going to have thinner, less attractive, less extensive, expensive coverage for the other people who aren't going to get as much because it's going to be less income related. And it's not going to blow up. The last refuge of anybody who doesn't want to change health policy say, adverse selection, run for your lives. We never have that meltdown I'm always looking forward to, because it short circuits, because people are realistic about, no, we don't go all the way to the explosion point. You self-correct, you sell different products, you do it different ways. We saw this with all the bad laws of the 1990s. It never hits that explosive point. We move on to another set of disappointing, frustrating policies, and that's what we call a success.
You need a microphone.
That assumes a legislative. I'm asking before the legislative fix.
Could you repeat that in the microphone?
I'm just asking before the legislative fix. I understand the direction that the Republicans want to take the system, but I mean, before the legislative fix, you're still operating under the mechanisms of the current law, right?
Yeah, but you're already stuck for the next planned year in reality. I mean, you can't exit the next month. Just the bleed out of HIPAA alone buys you 3 months. You're there at the other end of the pyramid. Basically, you're looking for better days ahead. You've already compromised with a law which was bleeding you dry in a small part of the market, and you hung in another year, another year, another year. The same thing will happen in this case.
I would like to clarify that the you that Tom is referring to is Republicans. Republicans have to deal with this problem. Democrats can sit there and laugh. Another point that actually Tom made in my office, if you work here, you'll learn a lot of things that are pretty useful to know. So I'm going to give Tom credit for this, but I'll take the blame for getting it wrong. Part of the aspect here is how much, who has something to lose now? In other words, it's a bargaining situation. And leaving aside whether Donald Trump is really a great bargainer or not, this is a bargaining situation. It's the same bargaining situation that Barack Obama had 6 years ago. And so the question is, who's going to give? Who's going to say uncle? It's not obvious to me that insurance companies are all going to immediately exit every market. Let's
6
see.
years ago, insurers were concerned, where's our growth going to come from? We're stuck with kind of a flat employer market. We got to get into Medicaid, which they did. We've got to get into, other areas of an expansion. And if you give us some subsidies, we can sell this stuff and we'll come out ahead. And they put some stuff on the table in return, thinking they would eventually make up their losses on volume. It didn't happen that way under the ACA, but there's hope springs eternal.
Okay, we have time for about one more quick question. And actually, you still want to ask that question? Because I think, were the next person that I saw.
Hi, Shannon Firth. I'm from MedPage Today. I just wanted to ask about winners and losers if the subsidies are changed to a tax credit system that is age-based, and how do you, if we had the problem of getting young invincibles into the market before, how will that change with changes to age banding and the subsidies? Who are the winners and losers in the replacement plans?
Winners. Lower middle income white males, slightly older, poorly educated. Go with the folks who vote for you.
That's definitional as opposed to real.
Under any sensible rating system, younger people who might not qualify for subsidies under the Affordable Care Act should be winners under the system, because they will now get a tax credit to help them pay for coverage, and in addition, they won't have to pay substantially higher premiums to help subsidize older and less healthy people. So there'll be less of that compression of premiums that does harm younger people unless they qualify for a major subsidy under the Affordable Care Act. Losers is going to depend a lot on the detail. The refundable tax credit programs, it's not clear, and Robert mentioned this, it's not clear how that will work in terms of providing the same amount of subsidy or a comparable amount of subsidy as currently arises under the Affordable Care Act for people at, say, 150, 200, 250% of poverty. But that's going to obviously be very politically sensitive. If we see significant reductions in the net subsidy under some replacement plan for that group of the population, that will be politically controversial, to say the least.
Let's see. Yeah, we really have run out of time. So anybody who has questions for this panel, ask the next panel. You're liable to get better answers. Now, if we can, let's try to change panels very quickly. So thank you very much, and please join me in thanking the current panel.
Am I on here? No? Try that again. Here we go. Okay, there we go. Try this again. Good morning, everyone. Let's try that. Let's get this right. Good morning. This is the second panel of our event today, and I'm very pleased to moderate it. My name is Jim Capretta. I'm a resident fellow here at the American Enterprise Institute, and we have a very distinguished panel whom I will introduce in order of how they will speak this morning. Just a word about what we're going to try to do here. Obviously, that first panel covered a lot of issues and a wide range of subjects associated with the status of the ACA going forward and its potential repeal and replacement. These folks are going to be able to touch on all those same topics too, but we want to focus a little bit, at least in part, on the how. How would you go about doing this in a legislative sense? Because I think in lots of times, but particularly in this case, the procedure and the process that is decided on for moving forward with something actually could very materially affect what is done. And so maybe thinking through the implications of the various potential paths can help folks see where they might end up if they go down that particular road. So a little bit this morning on the how of doing this, because it's quite complex, as you'll hear as we move forward. But let me introduce our panelists. The first speaker will be James Wallner. James is the Heritage Foundation's Group Vice President for Research. He served on the Hill in various capacities for a decade, including for Senator Jeff Sessions and others. He received his doctorate and master's degree in politics with distinction from Catholic University. And he's written 2 books that are relevant to our conversation here this morning, especially the one that will be coming out next year from the University of Michigan Press, entitled On Parliamentary War, Partisan Conflict, and Procedural Change in the United States Senate. Our next speaker will then be Doug Badger. Doug and I have known each other for a very long time, longer than we probably want to admit. He's had an incredibly distinguished career working both in the legislative and the executive branches. I worked with him very closely when we both served in the administration of President George W. Bush. He worked in the White House as a top healthcare policy advisor to the president, and then later as a key person in the Office of Legislative Affairs. He worked on the Hill in various capacities, including a long stint with Senator Don Nichols from Oklahoma in his capacities in Republican leadership. Our third speaker will be John McDonough. By the way, also, Doug is now currently a fellow with the Galen Institute. John McDonough is the professor of public health practice in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health. Between 2008 and 2010, he served as a senior advisor on national healthcare policy reform to the U.S. Senate Committee on Health, Education, Labor, and Pensions, where he worked on it and helped pass the Affordable Care Act. For 5 years prior to that, he served as an executive director of Healthcare for All in Massachusetts, where he was an instrumental player in helping lead the push for Massachusetts' reform under Governor Mitt Romney in 2006 and its implementation. He's written many different books. Probably most relevant for our discussion today is Inside National Health Reform, his story of what went on behind the scenes in the push for the ACA, published by the University of California Press and the Milbank Fund in 2011. So with that, I will turn it over to each of you to speak. I think we'll have 10 minutes for each of you or so, and then we'll have some discussion amongst us and some questions. James.
Wonderful. Thank you. Good morning, and thank you, Jim, and thank you to AI for hosting this debate, or not a debate, a discussion, I should say. It's wonderful. It's great to be in this beautiful old building. It's a little chilly outside, but I can tell you that the climate system here is certainly modern and ready to go. It's not chilly in here at all. But it's always good to appear alongside such knowledgeable and distinguished panelists, and I will do what I've tried to do in my life and associate myself with people smarter than myself so that you all will think that I know what I'm talking about. But as Jim said, we're going to talk a little bit about the how of healthcare reform and how we can expect it to play out. And in this instance, as we've all been reading in the newspapers over the past couple of weeks, the how is just as important, I think, as is what can happen. And I'm just going to emphasize very briefly 3 points, I think, to help frame how you think about the how of healthcare reform. And the first one, which I think is more apparent now than it has been in the past, is that the Republican Party is not as unified on repeal as it has appeared to be over the past 7 years. The unity around the repeal effort is really striking if you think about it. Other than the idea of repeal and replace, there's been no qualification whatsoever in repeal. The early messaging was it taxes too much, it spends too much. We've had our leaders say we're going to tear it out root and branch completely. And this has been a consistent message from literally every single candidate for office that has been running on a Republican Party under the banner of the Republican Party for the past 7 years. And this has implications that I'm going to return to in a little bit. That unity, one could suspect, could be a function of the expectation that we would ever be in a position to actually follow through and repeal the law. It could have led members to be a little bit more aggressive than privately they may have wanted to. But it is a reality. It has created a new political reality for the party. Another point here I would like to emphasize is the 2015 reconciliation bill. As you recall, last year the House and Senate both passed reconciliation bills. They were then reconciled, and the president ultimately vetoed the last bill. The 2015 bill, the House originally passed a bill that didn't repeal much of Obamacare, of the ACA. It certainly didn't repeal everything you're allowed to do under the rules, under the budget rules governing reconciliation. More or less, it basically repealed the individual and employer mandates, medical device tax, that sort of stuff. It came over to the Senate, and the Senate was ready to go to pass the same bill. A couple of senators said, no, we're going to demand that we repeal everything we can under the rules. And so that's what ultimately led to the 2015 reconciliation bill that the president vetoed. But even that process was a struggle. As I mentioned here, with the House passing a bill that wasn't as aggressive as it could have been under the rules. And then in the Senate, there was a very aggressive debate in private behind closed doors as to whether or not that bill should actually be expanded. So even at a time when the bill was going to be vetoed, it wasn't going to become law, there is a very aggressive private debate playing out as to how hard the Republicans ought to push to repeal. And this is important, I think, because time is important here. A lack of unity becomes more apparent as time plays out, and also the repeal effort begins to compete with other legislative priorities. And this is really important because in the new Congress, there's only going to be 52 Republican senators. And if you expect all Democrats to vote against any repeal effort, you can only lose 2 of those and still pass with a simple majority using the vice president in his tie-breaking vote. The second point I want to make here is there's been a lot of talk, and I'm sure we'll discuss it today, about what is the sequencing here? Repeal and replace at the same time? How should it work? And as a practical matter, as someone who has lots of experience in the Senate and in Congress and seeing how things play out, the only thing I see that can be possible here is to repeal first and replace later. And this is just a practical matter of no Democratic senator is going to vote for a bill to replace Obamacare, as long as that bill is coupled to a repeal of Obamacare. I mean, that's just a fundamental point. And so, therefore, it seems to me that you have to first repeal. Now, we did pass this 2015 bill, and that seems to be the floor. We can potentially get more, and I'll mention that in a second, but it definitely is the floor. There's some talk about, well, maybe we can figure out a way to keep the taxes, or we can figure out a way to bank the savings so that we can use them later on. But that kind of talk also runs head into the messaging, going back to the unity on this bill, that has been propounded by every single Republican since the beginning of this fight, which is it taxes too much, it spends too much, we've got to repeal it all, root and branch. Well, if you say that for 7 years and then you turn around and say, well, maybe we should keep the tax increases, that doesn't make a lot of sense to the people who are supporting you. There is, the argument that the 2015 reconciliation bill could be expanded to include a lot of the insurance mandates. that were included in the original legislation. I think there's a good argument you can make. You can make that case, but we don't know yet. That is a debate that's going on right now behind closed doors with the Senate parliamentarians, with the leadership and the budget committees in both parties. And that's a debate that's going to play out. It was something that was not adjudicated in 2015 when the reconciliation bill was originally debated the first time. One thing I will say is I'm a bit of an optimist here when it comes to the insurance regulations. Even if the 2015 bill is the floor, and that's all you can, is the ceiling, and that's all you can get, and you can't come back for the insurance regulations. And as we heard from the prior panel, those things will significantly drive up cost, and if you remove the subsidies, that creates a problem. And it creates a lot of problem for certainty in the market and for consumers. But in an environment where repeal has already occurred, you can have a debate as to what regulations you need. You can have a debate as to what insurance regulations you can need. And a lot of people right now say, well, we're not going to do that. A lot of Democrats, we're going to make the Republicans own it. As someone who has advocated that kind of thinking to many, many members I've worked for over the past 10 plus years, I can tell you that is not going to happen. Voting, for the most part, is a dichotomous choice. Members of Congress confront a status quo, and they're confronted with another proposal, and they're asked to cast a vote. And if the insurance regulations are causing havoc in the marketplace, there will be a demand to vote one way or the other. And I'm also going to return to this other point. Regular order here is critical. If you allow members an opportunity to have a say, to offer amendments, to debate alternatives, to vote down or at least try to vote down things they don't agree with, then it's going to be very difficult for them to sustain an obstructionist position ad infinitum. It's just not going to happen. In my experience, it never does happen. When you have obstruction that never pans out and actually moves on to produce outcomes in terms of bills is when you have gridlock, when you don't allow members to offer amendments, when you don't allow them to debate. So I'm actually an optimist here when it comes to getting rid of the insurance regulations via regular order if they're not allowed to be dealt with in reconciliation. And I think that is the key first point the first step in the replace effort. Repeal everything you can now, and then immediately turn to the insurance regulations, and then start to work through the very difficult debates that we have to have as a country about what kind of healthcare system we ultimately want. The third point I would say here is that when we do get to after the repeal point, part of the debate to replace, then that needs to be more of a step-by-step approach, and I think it needs to be done via regular order, unlike the original legislation here in question. It doesn't need to be done via reconciliation, it seems to me. Bob in the first panel mentioned a lot of this, but we have, when you write something in secret, when you jam it through, when you don't allow people to have any say in it, then you get the kind of situation we're here talking about today. And so again, I think that you break this thing into more manageable pieces. You go through a step-by-step process. You allow for an open debate where the members and staff and the American people can weigh in on what they think is and is not appropriate. And I think you're going to get to some good outcomes. It's not going to be great. Not everybody's going to be happy. I certainly am not going to be happy with it all. But I think we've seen over the past 8 years that that's the way the system ought to work. And when it doesn't work that way, everyone ends up being unhappy. Just in conclusion, I would say three very short things. One, we put too much emphasis in our discussions of this issue in particular, but all issues, on this idea of what is the silver bullet plan? When are all the members going to go into a room and talk it out and come out with a big idea, and that idea is going to give everybody certainty and everybody's going to love it, and we're going to go off into the sunset and we're all going to be happy? That doesn't work. It just doesn't. No one should have an idea that that kind of thing works. We have a legislative process for a reason. We have rules in the House and the Senate for a reason. Guess what? They actually drive us to outcomes. And when you follow them, you will get to an outcome one way or the other. And it allows for a debate to play out, and it allows for the American people to take stock of that debate and then to weigh in on what kind of system they want. And so the idea that we can't start this process until we all come up with some silver bullet that all the Republicans or all the Democrats or all the Republicans and the Democrats can agree to is going to mean that we never get started in the first place. The next point I would make is that the Republican Party has raised expectations on this issue. I think that's the understatement of the century. And going back to this idea of false unity, if that actually becomes apparent and they're unable to do this, or if they say, well, we're going to repeal everything but the tax increases because we want to use that money that we've been attacking for the past 7 years as being bad for the economy or immoral or whatever you want to say, we're going to use that for our healthcare plan. That becomes a very difficult proposition for the people who have been voting for them. And then lastly, with the election results of this past November, there are no more excuses. We've heard from the Republican Party time and time again, give us the House, everything will be okay. Then it's, well, we need the Senate and everything will be okay. And then it's like, well, we can't do anything without the presidency. And now we have unified government heading into the next Congress. And right now, if the Republican Party doesn't deliver, it's going to be very interesting to see what happens, because I don't think anyone interprets the election results as somehow a vote of confidence in the Republican Party, right? That's not what happened in November. The people are frustrated and they're fed up and they're tired of excuses from both parties. And I think it's incumbent upon Republicans to follow through on their repeal effort and the promises that they've made over the past 7 years, and then to take a step back and let the process play out on how best to replace the law. So, thank you.
Very good. Doug.
Slides. Thank you, guys. Like Tom Miller, I have a slideshow here, I believe.
And I think you should be good to go if you hit forward.
And there we go. And my goal today is to add a third R to repeal and replace, and that is rescue, because I think that one of the first things that President-elect Trump will encounter as White House, as the new president, and that the new Congress will have to deal with, is the fact that there is generally a failure in the individual markets in the ACA. I'm not talking about the small group markets. I'm not talking about Medicaid. I'm talking strictly about the individual markets. The 2015 risk corridor data that CMS released last month document this to some extent. The risk corridors were alluded to in the earlier panel, but essentially the idea is to transfer excess gains from some insurers to their competitors who made excess losses. And what we found out is that in 2015, the excess losses more than doubled from 2.2 billion to 5.2 billion, that losers outnumbered winners by 5 to 1. And that even in California, which is taken as a state where the ACA individual markets are working, excess losses outnumbered excess gains by a ratio of 282 to 1. Now that was 2015. Since then, things have gotten bad. We've seen 4 of the 5 largest insurers withdraw from most of the exchange. The 5th, Anthem, the CEO, and this was prior to the election, said on an investor call that he may pull his plan also off the exchanges in 2018, and his stock price spiked upward in a matter of minutes. Even the Blues plans have pulled out of several states. It's a real quandary that this is now the new administration's problem, because we've already got the narrative out there that President-elect Trump is responsible for the crash in the ACA individual markets. So it's a problem that's waiting for him on the desk at the end of the inaugural parade next month. And there's also a general political context you have to be aware of, which is that think tanks are competing with each other over just how many people will lose coverage if Republicans repeal and replace Obamacare. The figure the administration uses is that 20 million people gain coverage under the ACA. I think that's an inflated figure for a variety of reasons. But even if we accept that, the latest bidding is that 30 million will lose coverage if a Republican replacement is put into place. So that is the political context that's going to surround the House deliberations. So I'm going to lay out now 3 possible pathways for how this plays out as Congress moves forward on repeal and replace. The first, I think, is the one we've heard the most about, that there would be a 2-step process. First a repeal bill, later a replace bill. The repeal bill starts with a budget resolution. A budget resolution does not have to be signed by the president. It's a simple majority vote in the House and Senate, and it will provide reconciliation instructions to the various committees. Now, the House says they're going to start work on the budget resolution on January 3rd or 4th, immediately after being sworn in. So they're hoping that this moves very quickly, and then to a reconciliation bill that we'll talk about in a little more detail in a minute. And, generally they're talking about completing that process of a budget resolution and a reconciliation on the President's desk by the first part of February. So we're talking about a very, very abbreviated 5 or 6 week process. At least that's where people are starting with their expectations. The second part is replace, and this is kind of lather, rinse, repeat. You do an FY 2018 budget resolution with reconciliation instructions. And to James's point, and also to the point that was made by Dr. Reischauer on the first panel, you are probably very, very limited in what you can do in a reconciliation bill. And so this is not necessarily the pathway they will follow, but this is a pathway at least that's been discussed. And that is something that will take a number of months to play out. So the previous repeal bill, there might go. I have poor clicker skills. The previous repeal bill, as was mentioned, didn't repeal everything. It did repeal the subsidies and the Medicaid expansion, but there was a 2-year delay. It immediately repealed, as James pointed out, a whole variety of taxes. It did not repeal all of the things in Obamacare, and there was a question after the first panel about what about ACOs, what about CMMI. There were things they could have repealed that they did not in Medicare and Medicaid, and as James pointed out, there may be things that they could repeal that the parliamentarian will allow to be considered on the Senate floor. And I will spare you a tutorial on the Byrd rule. Jim will have to do that one. But again, last time out, 2 Republican senators voted against him. One, Mark Kirk, is not coming back. The other, Susan Collins, is. So as James points out, a very, very narrow knife edge to get the repeal bill through. I do believe that they are going to have to address some of the rescue things in this bill. I know we had a question about that. One in particular is the cost-sharing reduction subsidies. These are the subsidies that were the subject of the House lawsuit that they succeeded at the district court level in saying that Congress had failed to appropriate these cost-sharing reduction subsidies and that the administration was spending them anyway. Now, the House prevailed on that point. It's still up on appeal to the D.C. Circuit. But I would say if the new Congress wants the ACA individual markets to continue for a couple of years, I would argue they need to appropriate this money, because you cannot take that money out of the system. If your objection is a constitutional one, it is something that you ought to address. Now, the challenges to the two-step approach are many. First is passing the budget resolution. The reason why there's no FY 2017 budget resolution when we're already coming into the second quarter of 2017 is Republicans in the House couldn't agree on spending levels. So the first thing that has to happen is that members have to understand that this is more or less a shell budget resolution which is being passed only for the purpose of allowing consideration of a repeal bill. But I don't think that's a done deal. The second difference that we all are well aware of, the existential one, last year they were passing a bill they knew the president would veto. This year they're passing a bill they know the president will sign. So that changes the mentality a little bit and brings out some of the potential concerns that James raised in his. Thirdly, enacting repeal without replace does fuel the debate that Republicans are just tearing everything down and they don't have anything to put in its place. And so all of those estimates about 30 million people losing coverage will become 40 million, 50 million, and the stars will begin madly shooting from their spheres. I mean, this will escalate the criticism that Republicans aren't serious about replacing it. And the fourth point is the Trump administration. All of this is happening at the time where shortly after the swearing in, when you're hoping to get some cabinet members in place, you really don't have established routines in the affected departments and agencies. Not to mention the fact, I don't know that the president-elect has signed off on this particular approach and set of priorities. So those are the challenges. The one-step approach talks about, again, a similar kind of procedure, but says, look, let's package the repeal and replace together. Now, as James points out, that looks a lot less like repeal and replace than it does like amending or fixing the ACA, and that may cause some angst among folks. And so it does face some challenges. The first being that for 7 years Republicans have said they were going to repeal it, and the first thing they do is say, well, let's wait and not repeal it until we can agree on what replaces it, and that's going to be something that can be difficult to sell some members. Secondly, I think Joe Antos pointed out at the beginning of last time's panel, it's not that Republicans don't have replace bills, it's that they probably got a couple dozen of them. And the problem is there's no consensus around any one of them, and so the question is, will that consensus continue to prove elusive? The third thing is, the longer Congress waits, the more other things are going to crowd onto the agenda. The administration has its own priorities. There's a Senate bandwidth issue. They've got to do confirmations, executive branch nominations. They've got to deal with a Supreme Court nominee, resolutions of disapproval against regulations. The continuing resolution expires on April 28th. The debt ceiling resets on the 15th of March. If you don't act early on this, one argument is you're going to lose your window of opportunity and things are going to pass you by. And then finally, unforeseen events. The one thing we know about the Trump administration is that President Trump won't define what is going to mark that administration. Stuff happens. It happens in the world, it happens in the country, and how a presidency is ultimately judged is how they respond to those unforeseen events. And then finally, the no-step approach, which is more a product of inertia. We can't agree on a two-step, we can't agree on a one-step, and so we end up simply delaying action. So there's both a process and a substance. We can't agree on what legislation we want. But I think that's a very short-lived discussion, because by the time we get to the middle of next year, it's going to become apparent that no insurers are going to be coming into the exchanges in some states, and they will be sitting out of a number of counties in perhaps numerous states, and so you're going to have to do something to address that near-term issue, and that leads you, I think, naturally into the taking one of these approaches. Finally, for those who want to bet along with me, and I would strongly advise against it, I would say that the two-step approach probably is still the highest priority as of today. I don't know where people are going to be a month from now, but if I were handicapping this, I'd say it's a very, very high probability. A lesser is the one-step approach, although there still are members and others who call for that. And the no-step approach probably is a negligible probability, but never bet against inertia when it comes to the legislative branch. The ultimate irony is that it may be the urgency of rescuing the ACA that ultimately motivates its repeal and replacement.
John.
Thank you. Nice to be here. Thanks, Jim. Thanks, Joe. Thanks, Tom, for having me here. When I left this morning, Boston, it was 5 degrees, so really nice to come down to a warmer climate. And this is a beautiful new headquarters. Congratulations. And I also want to congratulate you for being so in step with the tenor of the incoming Trump administration by having a panel with 8 older white guys on it. Really in step. Now, I'm sitting in Tom Miller's seat, so that means, from what I understand, I'm required to make a movie allusion. So the movie I would call to your attention is Ghostbusters 1, okay? Forget 2 or 3, okay? But Ghostbusters 1, you remember there's the 4 Ghostbusters, they capture ghosts, they put them in a containment facility in the bottom of a former New York City firehouse. And the nemesis of the Ghostbusters is an attorney for the EPA named Walter Peck. And Walter, at one point, comes in to the firehouse and with utility workers from the city and the police, storms down to the basement where the container facility is and orders the utility workers, says, "Shut it off, shut it off." And the Ghostbusters are saying, "You really don't want to do this. You don't know what's going to happen. Bad things are going to occur. Please, please don't do it." And Walter Peck says, "Shut it down, shut it down." And they shut it down, and quite literally, all hell breaks loose. I offer that as a metaphor. Now, people on my side of the fence would welcome the opportunity, and welcome and thank you for having us at this table, welcome the opportunity to offer our insights and advice. And I do notice this past week that Donald Trump invited Zeke Emanuel to Trump Tower to talk about it, so let the healing begin. But let me focus just a few points. The central matter, I think, from our perspective, that stands in our way of feeling comfort with this process and where we're going. We've had heartening words and heartening promises from Donald Trump, from Paul Ryan, from Mitch McConnell, that no one is going to lose coverage, that it's going to be just as good, it's going to be better coverage, and it's going to cost less. And if that can happen, yippee, we're all for it. But the thing that stands in our way is the reality as we look at the plans that have been advanced by Donald Trump, by Paul Ryan, by Tom Price, by AEI. It doesn't come close to the levels of coverage and support that we have now. And we see in the reconciliation bill from a year ago and others, let's repeal those taxes so fewer dollars. When you move from an income-based subsidy system through the premium tax credits to a flat one, you're going to put it at a level where most of the people who get the subsidies today, it's not going to be nearly enough. And so we are looking at potentially, and we don't know, but this was the estimate not from Democratic think tanks, this was from CBO a year ago, scoring the reconciliation bill. 22 million people would lose coverage with the reconciliation bill that the president vetoed last December. So there's major issues in terms of it. And I guess, business people are in charge, and we're being asked, let's repeal the financing and trust us. What comes next is going to be much better. It's going to be good. What business man or woman would accept that kind of a deal? So that stands in the way. But that's not also. Another major concern, guaranteed issue. It is heartening that the president and the speaker and other folks say, yes, we're going to continue guaranteed issue. But as we've heard today from the first panel and from others, there's fine print after it. It's guaranteed issue for people who maintain continuous coverage. And the people who don't maintain continuous coverage are sent into the 7th circle of hell of medical underwriting. I mean, we've gotten this out of our system. It's gone. Rating people based upon their prior illnesses, their chronic illnesses, their gender, whether they've ever been a victim of domestic violence, all that is gone. And if you look at the AHIP letter that was sent last week, they're not hungry, oh boy, let's get back into medical underwriting. They don't want to go there. And I don't know why we want to go there. So how do you maintain continuous coverage? How long is the gap? And when you're sent into the 7th circle of medical underwriting hell, how long do you live there for before you can get out again? And how many people are we estimating are going to fit in to this circle? We've got 28, 29 million uninsured now. They're all going to start out on day one in the circle of hell. There's some number, according to your subsidy scheme, of the 20 million who are going to lose coverage, who are going to fall into it. And then the next recession, people are going to fall out. What are we talking about here? No one is demanding, I don't see anyone in society demanding it, and I think there needs to be a little bit more being on the level with people that we're talking about preserving guaranteed issue for some, for privileged people, but the people who are going to fall into that circle of hell, they're going to be the lower middle income people, they're going to be the people who have chronic illness, they're going to be the people having a tougher time in the world, they're going to be the Trump voters. If you saw the Economist chart, right? Donald Trump won the vast majority of Americans with chronic illness, lower income. And Hillary Clinton won the higher income, healthy people, right? But so I think there's got to be much more understanding, and I just find it disingenuous to say, oh, we're going to keep guaranteed issue and leave out that important clause, because that important clause is going to matter a lot to tens of millions of Americans. I haven't heard any estimate how many people, but let's get that out there. A third issue, mental health and substance abuse, otherwise known as behavioral health. The ACA happens to be one of the most important laws in the history of this country in advancing medical care and treatment and access for people who have mental illness and substance abuse. Guaranteed issue. Essentially important in terms of not having a prior mental illness or current or substance abuse held against you when you're trying to buy insurance. Eliminating lifetime and annual benefit limits, incredibly important if you have serious mental illness. The essential health benefits. So behavioral health is one of the 10 essential health benefits, and prescription drugs is one of the 10 essential health benefits. These are just a few of the things that are critical. I don't hear any clear conversation from my colleagues or people who are in charge of this on how are you going to keep this together? How are you going to not make this worse? Because these are the people who are on the firing line in terms of losing coverage, and there's a bipartisan kumbaya. We want to deal with substance abuse and mental health and folks who are falling into this really deep systemic problem, but I don't see people facing up to the consequences for them of what's going on. Fourth concern, hospitals. So hospitals came up, stepped forward in 2009 and made a deal with the White House and the Senate Finance Committee. We will give up $155 billion over 10 years. Now it's $350 billion over the current 10-year period to finance the coverage expansions in the ACA. And they did it. And they did it, and they stepped up to the plate because they wanted to get the monkey of America's uninsured off their back. And they made a commitment, and they stuck to it. Now we see in the reconciliation bill that you're going to repeal the taxes for the high-income folks through the Medicare payroll taxes, the unearned income and the earned income. You're going to repeal the taxes on the drug companies. You're going to repeal the taxes on the insurance companies, on the medical device. Heck, you're even going to repeal the taxes on the indoor tanning salons, which is probably the most important public health measure in the whole damn law, if you know anything about melanoma among young women and how they're getting it and where they're getting it. Anyway, so you get all those things, but the hospitals who are going to be on the front line of the tens of millions of uninsured, you're saying, well, you're going to keep those cuts. So last week, American Hospital Association, Federation of American Hospitals sent a letter saying, hey folks, if you're going to repeal all this stuff, we want our money back. Is that so illegitimate? But I think, this is part of the disingenuous that we see going on. Democrats were pilloried for cutting Medicare, cutting Granny's Medicare to pay for Obamacare, and then in budget after budget, when Paul Ryan was budget chair, he'd repeal the whole ACA except for the cuts to Medicare. He'd leave them in all the time. So there's this opportunistic thing going on. So I think if you're going to be fair to hospitals, you gotta address that. And we don't hear anybody on that saying that, but there's a problem with that. And the problem with that is that if you do give them that money back, you increase the costs of Medicare, and you're going to increase the premiums in Part B and Part D for all Medicare enrollees, and you're going to substantially shorten by, I forget how many years, the life of the Medicare Part A hospital trust fund. So you're on the horns of a dilemma, but where's the fairness here? Where's the fairness in saying everybody else who's been paying taxes, whether they agreed to it or not, gets a big break, but hospitals, tough luck to you guys, good luck caring for 20 million new uninsured coming through your doors for services, okay? Last thing I just want to mention, the last thing I'll say, this is about the exchanges, okay? An idea, by the way, from the Heritage Foundation. That's where it was Heritage Foundation folks who came up to Mitt Romney and said, you really got to create these health insurance exchanges. That's where the pedigree is. One of my colleagues at the Kennedy School, Ron Heifetz, he likes to say, there's two kinds of problems. There are technical problems, and there are adaptive problems or system problems, bigger things. And I think we need to have a more thorough discussion about the problems with the exchanges. Are these technical problems or are these systemic adaptive problems? And I think it'd be fair to say all three of my colleagues here and in the former panel would say, oh, these are big systemic problems. I would challenge that. I would challenge that. I give the example of Alaska. Alaska this past summer saw their premiums in their individual market going up 42%. And the Alaska legislature, Republican controlled, said we can't let that happen. So they got together, they created a state reinsurance program for their individual market, exchange market and non-exchange. And overnight, the premium increases went from 42% down to 7%. California doesn't have a broken market. Other states don't have a broken market. We had a good exchange structure with premiums under control in 2014, 15, 16. It's going haywire in 17 because the risk corridors and the reinsurance are out. The risk adjustment has gotten messed up because of political fighting in Congress over it. But these are not systemic problems. These are fixable problems if there was a will. I spent 13 years as a member of the Massachusetts legislature, and I learned something in those years because we had joint committees, House and Senate. So I was a House chair and I had a Senate co-chair. And when the Senate co-chair and I, when we trusted each other and we could get along, the most difficult things could get done with ease. And when we didn't like each other, we couldn't schedule a darn hearing. We couldn't agree on lunch. It was just impossible. And so that is the problem, but it's not that there's a deep systemic failure of the exchanges. It's going through a very rocky period right now because, if we'd had a conference committee in time, we would have maybe made the 3 Rs permanent like they are in Medicare Part D. Why does reinsurance, risk adjustment, and risk corridors both a communist plot and a bailout to the insurance industry in the exchanges, and they're as American as apple pie in Medicare Part D? Can someone explain that to me, please? Okay, well, wait for your turn. Because you'll get it. Anyway, so love to help you. And we got some stuff to talk about.
Thank you very much. Excellent presentations by all three. I'm supposed to be the moderator of this, but boy, I just have so many things I'd like to say in response to these comments. But I will, restrain myself a little bit here. Let me let Doug talk about if you would like, the 3 Rs.
Well, I could talk very briefly. I'll give you the short answer. First of all, the risk corridors in the Part D program, which should be repealed. The government has made money every single year on those. In the ACA, I keep saying Obamacare. In the ACA, you've got them losing money every year at an accelerated pace. The other difference is, in the Part D program, Congress provided for money to be appropriated in the case of a shortfall. In the ACA, they did not, either, according to the Comptroller General, they neither authorized or appropriated money. And actually, the Congressional Budget Office and CMS predicted that they would make money in risk corridors. So there's a problem. You can't legally spend the money. On reinsurance, I will say again, Comptroller General's opinion, September 29th of this year, CMS was required by law to remit $5 billion to the Treasury and not distribute them to the insurance company. The Comptroller General, in a very strongly worded legal opinion, indicated that that was unlawful. So the difference between the two programs, what they share in common is the same name for those programs. The difference between the two programs, by and large, one is lawful, the other is not.
So 16 years ago, the market in our healthcare system that was a holy mess was called Medicare Plus Choice. It's now known as Medicare Advantage. And if people took the attitude toward Medicare Plus Choice in 2000 that we're taking out to the exchanges, we would have tossed this whole program out. Enrollments were plummeting. Insurers were dropping out in markets all over the country. There was a massive number of counties in the United States that had no Medicare Plus Choice plan at all. And rather than saying, stupid idea, off with its head, out the door, mostly Republicans in 2003 in the Medicare Modernization Act, when Jim was in the Bush administration working on it, fixed it. We think they fixed it too much in creating Medicare Advantage, but it got fixed, and now it's a healthy duck sailing along, having a good time. And by the way, massive accusations at Democrats in 2009 that we were plotting to kill Medicare Advantage. It's never been healthier than it is right now. So again, yes, problems, issues, where people have a mind of let's try to fix things and make them work. You can do all kinds of stuff. And the problems in these markets, it is not systemic, it is fixable, when there's political will to do it. And if you guys want to keep these exchanges going over the next couple of years so that you don't have chaos and a collapse, you're going to just rediscover the value of these mechanisms in these markets.
Let me just jump in here on this particular part of the conversation. It's very important. A couple of things I'd say about what John brought up about the exchanges. I actually sort of agree with you that the concept of an exchange actually providing consumer information in some transparent and clear way to help them decide on what insurance option they want to enroll in, I'm for that. The question is whether the combination of the individual mandate and the guaranteed issue and rating rules that they put in place, which I really don't call the exchanges, they're really insurance market regulations, whether the combination of the individual mandate, how it's being enforced, the tax penalties, and the insurance rules, whether that combination was calibrated right to be sustainable. Now, I agree it might be able to be calibrated right to be sustainable, but I don't think they calibrated it right to be sustainable because I think the penalty on the individual mandate probably had to go way up. And by the way, Democrats in the Senate Finance Committee all voted to bring it down right at the key moment. And so there's no one to blame.
Because of you guys.
Oh, if only
No, because you're making
we made
this
you
a
do it, huh?
holy bloody shirt issue around the individual mandate after it was your original idea.
Well, maybe, John, maybe there's a question here of what's politically sustainable. Okay, so how much can the individual mandate go up and be politically sustainable in a way that would stabilize the market in a calibrated way to kind of make it sustainable? People will come to different judgments about that, and I think continuous coverage protection is really just another judgment about what our political process and our political economy can reach some kind of sustainability over time. It's one thing to tell Americans, I think, you have to buy an insurance product. It's another thing to say you have to take some personal responsibility. You will have a pathway to always have insurance, and if you decide not to have it, even for low-income people, you will always have a pathway to have insurance under these plans. If you decide not to have it, and you're going to say, well, the insurance is too skimpy, and et cetera, well, insurance needs to protect people first and foremost for big events. And if someone decides not to have it, then what are the consequences? Would they be unlimited and forever, and they wouldn't get health care? I don't think any of the Republican plans really want them to do that. So, look, I mean, there's a huge question of calibration here. I agree. But I wouldn't say that the calibration on the individual mandate plus the insurance market reforms has got it just right. And, I'm not sure that they found out the combination on the other one yet either. I'll agree to that, and I'll concede that. Let me though then. No, I'll let you respond to that in just a second. Let me turn to James here. We're really short on time, and I want to make sure we talk through this one question, which I think is really central to the how of all this, which is James brought up the point that the level of political commitment to repeal was very, very high. And now that they control the White House and the Congress, what excuse would they have not to move forward? And I certainly have a certain degree of sympathy with that point of view. But I must say, maybe my ear is a little bit, I don't know. I always heard, and I do believe, I think when Mitch McConnell came out the day after the ACA was signed into law, I could have sworn I heard, and I bet you he did say, repeal and replace. And honestly, when I watched candidate Trump on the trail, he never really ever said repeal. He always said, we're going to repeal and replace the Affordable Care, Obamacare. Now, why is this important? It's important because James's presentation, I'm going to give you time to respond to this, it seems predicated on the notion we're going to repeal because we know we want to do that. And the replace thing is big and messy and complicated, and we're going to have to just work through that in a regular order process. But actually, I don't think that's what they promised. I think they promised we're going to repeal it and we'll replace it in some kind of clear way so there isn't uncertainty about what's going to happen to people's health care. And then the reason why they connected replace with repeal is for the very reason that promising repeal without replace would have been politically problematic, right? And so I think there's a little bit of a, kind of playing fast and loose a little bit with some of the wording of what was actually promised on the campaign trail by which politicians at which point in time. So I kind of reject the notion, frankly, that the promise was repeal only. I don't think that's what they promised. I never really heard that. I know some of the members are committed to that, but that's actually not what I heard. And so, what would you say in response to that?
No, I take your point, and the message has been repeal and replace. Just a little bit of history. The reason why it's repeal and replace is because, one, it's, I think, good politics, and it's a rhetorical device. Repeal and replace was the response to those who were pushing at the time just repeal. But I don't think anyone was arguing that the status quo ante was good. I don't think anyone says, let's repeal it and then all hang up the cleats and go home and then just, have a good, just a good time and don't worry about it anymore. I don't hear anyone saying that either. But the question was, where was the emphasis? And then repeal and replace was a rhetorical device for a very long time. But there are a number of replace plans that have been proposed out there. There are a number of different ideas, and those ideas ought to be considered in the way that the ACA ought to have been considered in the first place, which is via an open and deliberative process where everybody gets to weigh in. A lot of the problems that we're talking about here are because the process was basically organized to force through this piece of legislation. Whereas if it was a little bit more open, my guess would have been that, maybe I wouldn't have been happy with it, other people might not have been happy with it, but it had been a lot more sustainable. It would have had more bipartisan buy-in. But instead, the idea was, we have all the answers and we're going to jam it through, and if we can't get the perfect thing, we're going to jam through what we get otherwise. My point on repeal first and then replace, because no one's saying just repeal and call it a night, is that just as a practical matter, you're not replacing if you're also repealing. You're tweaking and you're saving, which presents, I think, political cost to the Republican Party given their commitment to repeal and then replace. But I don't think it was ever at a level of nuance or detail where somehow repeal and replace would be done simultaneously. And then finally, even had it been that way, it is, as a practical matter, an impossibility. Because I don't see any scenario in which you're repealing the law and replacing it with something else. It's not going to happen. What you're going to do is you're going to go in and you're going to fix the law. And that's something that the Republican Party is not open to doing so far as I can tell right now, judged on the message of the past 7 years.
John, I really should have given you a chance right away, but do you want to respond to my comments?
It's very widely believed that the individual mandate penalties are too low. I would counter that. I would say that the issue is not that the penalties are too low. I would hold out the example of Massachusetts. Massachusetts mandate penalties in its state law and under ACA, just as low, different formulation, but pretty darn low. Not at all equal to the cost of buying insurance, and yet, very quickly, with the implementation of Massachusetts Reform in 2007, we got the rate of uninsurance down somewhere between 2.5% to up to 4%, depending the measure you use to count, and it stayed there It stayed there through the evolution to the ACA. What's different? What's different is that the subsidy support for people buying insurance in Massachusetts was twice as generous in Massachusetts as in the ACA. And when the ACA came, Massachusetts put state dollars on the table to maintain the affordability what it had been under Massachusetts reform. And coverage has stayed very low. So I would say the problem is not that the penalties aren't high enough. The problem is that the subsidies are not supportive enough in terms of the real needs of families who are on the economic edge, who need to buy health insurance and make these decisions. And that's the place that needs change, not jacking up the penalties, which I don't think is politically saleable anyway.
Well, you've listed two places now where the ACA individual market has been repaired, one in Massachusetts and one in Alaska. In both cases, it's with state dollars. So
well, no,
it's a very
it's
interesting
industry dollars in Alaska.
Well, but the state had to put in place the scheme
but it's not
for
state money.
raising the money. Well, when the state takes it from one insurer and gives it to another, that's state money. But having said that, what I think we're starting to hear on both of these panels, very subtly and very softly, is that one pathway forward on this is, instead of the federal government usurping the regulation of individual and small group insurance markets, instead of trying to impose a uniform scheme that may work in Massachusetts but doesn't work in Alaska and doesn't work in Montana or Alabama or something, is one in which the federal government pulls back a little bit, provides resources to the states, holds them accountable for the use of the resources, but doesn't dictate to the states to the extent to which the ACA has done. Federal interventions into health insurance markets have been a series of minor disasters. This one is a little more than minor, beginning with ERISA, through HIPAA, now the ACA. At some point, maybe those of us in Washington might allow for the fact that we don't know everything and provide a little more discretion to states to organize their markets in ways that achieve the goals we all share. We're not arguing over trying to increase the number of uninsured. We're all trying to figure out how to change this law in a way that works. And maybe the answer isn't here. Maybe it's more in the states.
So this is the first time I've ever moderated a panel at AEI, and maybe the last, because they may pull me off of this job because I ran long. So we're going to have time for just like 2 questions, I think, and then we're going to have to wrap it up. And I saw this hand up first, and then we'll come over this way.
Hi, Jay Keys, Capital Advocates. First of all, great panel. You did moderate it very well, or are moderating it very well. I have a sort of overarching question, then I want to ask a detailed question about process. And overarching is, I think one of the criticisms of the Affordable Care Act, or Obamacare, depending on which side you're on, is that it was really about fixing insurance or changing insurance and not changing health care.
If I could just ask you to be pretty quick about it,
yeah.
because we're a little bit over time.
So what are some of those things that can be done outside of risk corridors? I mean, in this process, are any of those in the whole replace process, or is that a conversation for later? And to that point, is CMMI, Center for Innovation, Medicare, is any of that likely to be in the first part of the reconciliation piece, or again, are we talking about much later conversations?
Doug, you got any? John?
I just say if you look at the macro law that Congress passed bipartisan 2015 to address Part B, physician spending, and you ask yourself the question, the macro model and the MIPS, the new physician payment model, and you ask the question, does that continue and advance the directions set by Title III in the ACA? Does that reject it and throw it out, or is it a muddled mess in the middle? Seems to me that it's pretty clear that MACRA continues and strengthens the direction set in terms of health system change and transformation in the ACA. So there may be some playing around with the edges of CMMI, but if you pull out, you get rid of CMMI, MACRA, which was a bipartisan victory that they heralded, is in big trouble.
Which is why some of us wondered why a Republican Congress passed it, but that's another story.
Without paying for it.
Without paying for it. Yeah, Mike, I think you'll have to be the last question. We do need to wrap up.
Thanks, Jim. Dr. Mike Miller, I wanted to get back to something that Doug said with his 3 paths and James said about regular order, but taking off what John had mentioned, which was one of my favorite sayings, is that change happens at the speed of trust. He referenced it in the legislative arena. I've seen it in the private sector and particularly in public-private partnerships, the state and federal level. Given that Congress has an approval rating going back maybe a decade that's in the single low teens, and we're coming out of an election where it was on one side, lock her up, and the other side it was you're a tax cheating liar. How does that influence your thinking about what we can actually possibly do in terms of your prognosticating your 3 paths we're actually going through regular order, since this is a panel about how we're going to move forward? Thank you.
Yeah, I think the first thing that isn't unique to healthcare is we got to get more comfortable with conflict. Guess what? It's okay. It's good. That's what our system's built for. And through the process of having conflict with each other, you get to outcomes that the people like. And for those that don't like them, they feel like they were heard. And so, this I think speaks to the core of the problem we have in our healthcare system now, which is the way that this law was pushed through on both sides. The debate that happened has poisoned the well. And the best way to start over is to get rid of it and then to come back to the table. And the last thing I'll say, I know we're short on time, is I like to think of LBJ in Mansfield, right? And we think of LBJ as being this genius in the Senate, and he was in a lot of respects. But I think he was also a genius who was bounded in time. And had LBJ not been vice president, and had he stuck around in the Senate and managed the Senate of Mansfield, would he have been as successful? It's a little bit of a counterfactual, obviously. I submit to you that he would not have been, because the way he exercised power was ill-equipped for the Senate of the 60s, where you had a whole host of northern liberals coming in who didn't want to play by the old bull rules anymore. The Republican Party was getting a little bit more consolidated. Mansfield comes along, and his genius was to recognize he couldn't control it. And so what did he do? He took a step back. He let go, and he focused on facilitating the participation of all the different members in the process. And if any problems arose, he would try to work it out on the back end. And guess what? The Senate had its golden age, according to people on both sides of the aisle. And they tackled a lot of really difficult questions during that time. And I think that we have to have enough humility in our debate right now to recognize that no one person, particularly in the Senate, where a lot of this is going to be decided, is going to control it. Mitch McConnell's not going to do it. Chuck Schumer can't do it. They need to realize that they can't control outcomes, and they need to let the Senate work its will. Everybody on all sides of the debate needs to weigh in, and the best outcome hopefully will prevail. It may not, but again, that's the way our system is set up.
I think that's going to have to be the last word. Let's join me in thanking the panel.